Good evening to all of you. So, sorry for the technical delay that occurred at our Catheterisation department. I hope we will be able to complete the presentation within the allotted time. So, today's presentation will be on interesting case scenarios in the pediatric cardiac intensive care unit. We'll look at the case history of a 3-month-old male child weighing 4.95 kilograms. He underwent a PDA stenting in the newborn period, and the child was on aspirin before presentation to the hospital. Now, on presentation, the child had recent onset acute breathlessness with increased cyanosis. So, what could be the probability? This child had a neonatal duct PDA stenting. So, what would be the probable reasons why the child would have been put on the duct stent earlier? What are the diseases or the congestive heart disease the child was likely to have? Can I have some responses from the audience? So, it's a duct-dependent pulmonary circulation. So, usually the ductus is kept patent for maintaining the systemic blood flow, as in the case of a duct-dependent systemic circulation, or for maintaining the pulmonary blood flow in the case of a duct-dependent pulmonary circulation. So, what are the duct-dependent systemic circulation? This includes the hypoplastic left heart syndrome, the interrupted aortic arch, coarctation of aorta, and severe aortic stenosis. Duct-dependent pulmonary circulation includes pulmonary atresia, which is critical pulmonary stenosis, tetralogy of Fallot with pulmonary atresia, tricuspid atresia, or an Epstein's anomaly. So this baby on examination was dyspneic with a respiratory rate of 60 per minute. He was cyanosed with a saturation of 50%. Peripheral pulses were feeble. S1 was normally heard and S2 was feeble. Heart rate was 130 per minute. Other systems were within normal limits. So this child was obviously not in a very good condition. He was very blue and extremely tachypneic. So the child needed to be intubated in an emergency situation. So this is the chest X-ray you see with the endotracheal tube in situ. You can also see the duct stent, the radiological shadow of the duct stent in place. So echocardiography revealed diagnosis of pulmonary atresia with intact ventricular septum. The duct stent flows seem to be decreased. The patient had a restrictive AST with a right to left shunt. He had a hypoplastic right ventricle with muscle-bound right ventricular outflow tract. The great arteries were normally related with the RP and LP dimensions of 7 and 7.5. So now this, to summarize, this is a baby with a history of a PDA stenting, now presenting with acute onset breathlessness and extremely blue, and the echo revealing a blocked PDA stent. So how do you proceed with this case? Can I have some responses from the audience? So basically this child is very blue, so the child needs stabilization. The child was admitted in the intensive care unit, and he needed to be stabilized initially with emergent intubation. So following intubation and mechanical ventilation, we need to think about surgical options. So what are the possible options? So the options which I can see on the screen are balloon atrial septostomy with a BT shunt or an emergency BT shunt. So in this particular patient, as you can see in the previous slide, though the duct flows were reduced, were decreased, the pulmonary artery anatomy looked very good. The right pulmonary artery measuring 7 and left pulmonary artery measuring 7.5. So we considered the option of a Glenn shunt in this particular patient. So initially the patient was ventilated, he was stabilized in the ICU. Invasive lines were inserted which showed a blood pressure of 65/30 with a central venous pressure of 5 millimeters of mercury. Patient saturation remained at 60% and the blood gases showed a pH of 7.4, PCO2 of 36, PO2 of 30, a bicarbonate of 22.8 and a saturation of 65 with a lactate of 2.9. So this particular patient was considered for Glenn shunt with atrial septectomy because the branch pulmonary anatomy was looking very good and the child was already beyond 3 months of age. So someone in the audience has suggested a DT shunt. So what could be the problems of DT shunt in a young patient with a single ventricle? How will it affect the myocardial performance in future? So what are the possible advantages of a bidirectional Glenn shunt versus a DT shunt for this patient with single ventricle? So basically in a patient with atresia with intact ventricular septum and a single ventricle physiology, a bidirectional Glenn shunt will definitely offload the single ventricle. So in the long run, for better myocardial perfusion and decrease in the AV rehabilitation, a Glenn shunt would be a better option than the DT shunt, which would obviously increase the afterload to the systemic ventricle. So in this particular situation with good branch P anatomy, we opted for an emergency Glenn shunt and an atrial septectomy was performed under CPB. Now what is the indication for atrial septectomy in this patient? So atrial septectomy, obviously, it had a restrictive ASD, definitely correct. So a restrictive ASD, so atrial septectomy will permit more mixing of the blood and better saturation. So the atrial septectomy was also done under cardiopulmonary bypass. So in this particular patient, what are the monitoring lines that you will prefer at the time of surgery? And how will you interpret the hemodynamic parameters on weaning of cardiopulmonary bypass? So we need an arterial line for arterial blood pressure monitoring, and we need the CVP. So for CVP, where will you insert the lines? You need the SVC line. So what will the SVC line be detecting in this case after the bidirectional Glenn shunt? So the SVC line will be showing the pulmonary artery pressure or the Glenn pressure, whereas the IVC line or the central venous pressure will be showing the actual central venous pressure. So both these pressure CVP monitoring as well as the Glenn pressure monitoring is important to identify the transpulmonary gradient when you come off the cardiopulmonary bypass. So this patient on weaning of cardiopulmonary bypass had required an inotropic support of dobutamine at 5 micrograms per kilo per minute and epinephrine at 0.02 mics per minute. And he had a blood pressure of 90/48 with a mean pressure of 62. CVP in the right femoral vein pressure was showing a CVP of 7 and the right internal jugular vein pressure, which actually shows the PA pressure measured around 18 to 19 millimeters of mercury. And the patient had a saturation of 70%. Now in this particular patient, what would you comment on the hemodynamic parameters on coming off bypass? What would be your major concerns in this 3-month-old patient who had just undergone again surgery? Increased pulmonary artery pressure, definitely. So this particular patient is a 3-month-old child. So usually the Glenn shunt is performed at around 6 months of age when the pulmonary vascular resistance has come down. So now this emergent situation, we are in a situation where we have to perform the Glenn shunt as an emergent procedure. So there is a risk of increased pulmonary vascular resistance in the post-operative phase, especially since the surgery was done under cardiopulmonary bypass. So what are the possible causes? So this child had a saturation of 70%. In an infant whom the SVC drainage is almost constituting nearly 60 to 70% of the cardiac venous return, 70% is actually very low. So what could be the possible causes of low saturations in the post-CPB period? So as the participants have rightly told us, one cause is high pulmonary vascular resistance in a post-CPB setting where you have increased extravascular lung water, the effect of the pump on cardiopulmonary bypass, which is a systemic inflammatory response, and also the lung may get compressed during the procedure resulting in atelectasis or the presence of effusions blood in the closal cavity. So these can lead to presence of low saturations in the post-CPB period. And again, young age is a risk factor for high PVR in the post-operative period. So low saturations can be predominantly because of the high PVR setting or because of any respiratory problems like atelectasis or effusions in the post-CPB setting. However, we cleared the lung, we expanded the lung in the intraoperative phase, we decreased pulmonary vascular resistance. The hemodynamic stability was maintained with the help of inophobes and patient was shifted to the postoperative ICU. So in the ICU, the blood pressure varied from 100 to 112 with a diastolic of 73 to 82. Heart rate was 130 per minute. FEV pressures had come down by this time to 15 millimeters of mercury and IVC pressures of around 5. He was maintaining a stable urine output of 20 to 45 ml per hour. However, the saturations remained between 70 to 75%. On postoperative day 1, patient remained hemodynamically stable, had warm extremities, had a good urine output. However, the saturations had further dropped to 50 to 60%. ABG again showed a low PO2 of 31 and saturation remains at 57%. So now at this particular stage, what could be your strategies? What are the optimal ventilator strategies for postoperative lung patients? Yeah, so the optimal settings of postoperative ventilator settings in lung patients would require those settings where you get a very low mean airway pressure. So you tend to keep a low PEEP, as well as a low mean airway pressure. So you choose a ventilatory mode which will give a low PEEP and a low mean airway pressure. So usually the pressure regulated volume control mode is a suitable mode for use in these patients. And high PCO2. The participants have correctly mentioned the PCO2 because PCO2 is an area which is highly debated earlier. There is a concept that the low PCO2 can decrease the pulmonary vascular resistance, but it's actually the other way around, that is high PCO2. What is the advantage of high PCO2 in this particular patient? How will it help the blood flows? So it is mentioned that high PCO2 is advantageous. So how does high PCO2 help? So high PCO2 will increase, it's basically by its effect on the cerebral blood vessels. Hypercapnia will increase the cerebral blood flow and thereby it increases the cerebral venous return and pulmonary blood flow and thus the systemic oxygenation. So in a paper which appeared very early in 2004 in the JAC, so they have been the first to comment on the advantages of hypercapnia on patients with Glenn circulation. So it has been proved by a trial that hypercapnia, addition of carbon dioxide to the inspiratory gas, they were able to improve the cerebral blood flow, pulmonary blood flow as well as systemic oxygenation. Thereafter several studies have come up which have proven the importance of maintaining normocarbia or even a higher PCO2 to at the range of 40 to 45 milliliters of mercury in the postoperative period. What is the role of spontaneous ventilation in improving the blood flows or the pulmonary blood flow? Now, spontaneous ventilation actually creates the lowest mean airway pressure. So, early extubation is advocated in patients with Glenn physiology so that the pulmonary blood flows generates negative intrathoracic pressure and improves the pulmonary blood flow in these patients. So, post-operative Glenn patients are usually channeled towards an early extubation protocol. So, what about the hemodynamic management in these patients? Here you have to maintain the preload because the CPB is the driving force for the pulmonary blood flow. So the patients have to be adequately filled up and avoid any increase in systemic afterload. So in case if there is if the screening echo reveals the dysfunction or an AV valve reconjugation, you have to use measures to reduce the systemic afterload to maintain optimal hemodynamic status. And also you have to maintain anticoagulation in the postoperative period to maintain the blood flows. This is by heparin infusion. It is usually started at the rate of 5 to 10 units per kg per hour. So in this particular case, the patient was extubated and considering that the patient will benefit from early extubation by improving the pulmonary blood flow, we extubated the patient on postoperative day 2. However, the patient got reintubated after 12 hours. with severe respiratory distress. Now, at this point, the chest X-ray was taken, which showed left pleural effusion. An ICD was inserted, which showed left pneumothorax. And the patient also needed to be re-explored because of the presence of left pleural drains. Now, this patient we again considered for weaning following the reintubation once the lung conditions improved, but patient again had tachypnea and respiratory distress on weaning on postoperative day 3. He had increased tracheobronchial secretions with need for toileting. So, to clear up the pulmonary secretions, we electively ventilated the patient for another 24 hours. The pressure support ABG looked good and we attempted extubation again. However, immediately after extubation, patient desaturated, became tachypnic and was severely distressed. So what are the causes of, now this patient has failed extubation and there was a persistent low saturation which was noticed in the postoperative period. Now what are the causes of desaturation after a Glenn shunt? What would be your checklist for ruling out various causes for a blocked Glenn shunt? For blocked, correct? High PVR, blocked Glenn shunt, high pulmonary artery pressure, correct? High PA pressures, venous collateral. So we have a checklist for the various causes of desaturation following a Glenn shunt. We have to go systematically. So the causes of pulmonary venous desaturation include basically the lung parenchymal causes, which include the pneumonia, presence of pneumonia, effusion, pulmonary edema, or the presence of AV malformations. So this can be identified by, most of them can be identified by chest X-ray or by careful auscultation. Then there are causes of systemic venous desaturation. And you have to rule out anemia, again decreased systemic oxygen delivery, low cardiac output, so look for the presence of ventricular dysfunction. And again, another cause of decreased pulmonary blood flow will be increased pulmonary vascular resistance, which is very possible in this baby because he was of very young age. Presence of pulmonary venous hypertension, presence of a restrictive ASD, again that is not a probability here because he had a atrial septectomy, Glenn pathway obstructions, a missed left superior vena cava or decompressing venous collaterals. So how did we go about investigating this patient? So we looked at the chest X-ray again. You can see that the pulmonary lung fields are clear. It's more on the origamic side. The chest tube was seen in situ for draining the pneumothorax. So we did screening echo at the bedside. Sorry, the image is playing somewhat very slowly. So you can see that the ventricular function is normal. The atrial septum showed a fairly good size defect with good mixing, and there was no AV valve regurgitation. So we then looked at the Glenn flows. So this shows the screening echo at the bedside again shows good Glenn flows. Ventricular flows were adequate. And the patient did not have any clinical evidence of superior vena cava obstruction. So now we went ahead with ruling out the presence of collaterals. So the most important way by which you can rule out the collaterals by a simple bedside test of the contrast echo. Sorry, the video is not playing. Okay. Sorry, that went very fast. So that the contrast echo actually shows filling of the left atrium immediately within 2 cardiac cycles. So that shows the presence of obvious possibility of a venous collateral. So we then took the child for cardiac catheterisation, which demonstrated the presence of a decompressing venous collateral, which was subsequently coiled. So you can see the collateral, you can see the contrast and the collateral, and which was subsequently coiled. The coil can be seen in situ. So following this coiling and the obliteration of the collateral, patient could be successfully extubated after 24 hours. He was transitioned to elective CPAP to decrease the work of breathing. Now the blood gases show an improvement in the oxygenation. SATs picked up to 80%, and subsequently the patient was discharged home on postoperative day 15. So 2 months later we followed up the child. He was doing well with adequate weight gain. The Glenn flows were normal with a saturation of 81%. So the take-home message is that hypoxemia after blood is common, and a systematic evaluation is needed to close the diagnosis. You have to, in a young child, especially when there is possibility of high PVR, you have to systematically rule out each of these causes by simple bedside test. And if none of the tests are proving conclusive, we have to cap the patient to find the presence of either venous matters or maybe malformation, which is very common in this setting. Are there any doubts based on this case before we move on to the second case? He presented with good discoloration of lips and extremities. He was mildly breathless, which increased on crying. He was sinus, heart rate was 110 per minute, and blood pressure 84/45. Saturation was 72%. Now this is the chest X-ray of the patient. Can anyone comment on this X-ray? So this is basically chest X-ray which is showing orogenic lung fields. You can see the right ventricular hypertrophy is a typical boot-shaped heart, and a concave pulmonary artery segment which may indicate fibroblastic pulmonary arteries, and an underfilled left ventricle. So pulmonary oliguemia, right ventricular hypertrophy, and a PA segment is depressed. So the patient was taken for a echocardiography which revealed tetralogy of Fallot, a large conoventricular VSD, severe infundibular and valvular pulmonary stenosis, confluent good-sized branch pulmonary arteries being 6 millimeters each, and pulmonary anatomy was very good. 7.5 millimeter pulmonary artery annulus and a mean pulmonary artery of 6 millimeters. So what would be the future plan or the future plans for this patient? How do you optimize this patient for corrective surgery? So the current strategy is for early surgical correction. So the patient is obviously planned for surgical repair. So patient was planned for complete correction, was admitted in ward. In the ward, patient developed incessant crying. There is increasing cyanosis. Saturation dropped to 40%. Child became lethargic. So what is the most probable diagnosis? So this is the spell classification with the tetralogy of Fallot developing. Okay, so everybody has correctly said. So what are actually hypercyanotic or the test spells? These are paroxysmal episodes of cyanosis and hyperpnea, which is precipitated by agitation or irritability in the child with tetralogy of Fallot, which can sometimes be accompanied by syncope. Usually it is triggered by stress of crying, feeding, or straining or adjusting. So what are the physiological mechanisms for test spells? Tachycardia, decreased SVR, increased heart rate, stimulation of respiratory center, hyperpnea. So that basically covers most of them. So the mechanism usually includes an increase. Whenever there is an increase in the sympathetic activity, there is an increase in the heart rate, and there is an increase in cardiac output. Following this, there is an increase in the venous return. In the presence of a fixed obstruction to the right ventricular outflow tract, there will be an increase in the right to left shunt across the VSD. And this will reduce the pulmonary blood flow, which will lead to hypoxia and hypercarbia with a decrease in pH. That will stimulate the vulnerable respiratory control centers that will again precipitate hyperpnea. So this becomes a vicious cycle. So another mechanism which has also been proposed in the mechanism of chest spell is the infundibular contraction. The RV infundibular musculature is susceptible to effect of cateterisation, resulting in infundibular spasm and decrease in the pulmonary blood flow. So this is the mechanism of chest spell. So if the patient goes with chest spell, how will you manage? Suppose when you are examining a patient with a chest spell, you hear that you identify that the intensity of the murmur has become reduced. So what is your impression? Is it improving or is it worse? So actually the absence of a murmur indicates Absence of a murmur actually indicates there is no flow across the pulmonary artery. So the ejection systolic murmur or the systolic murmur that is here in the case of a Catheterisation is the murmur across the right ventricular outflow tract. VSD hardly produce murmur because of the unrestricted nature. So if you identify that the murmur has decreased in intensity, that may indicate that the pulmonary blood flow has come down drastically. So that is again a great sign. So how will you manage this particular patient? You will give supplemental oxygen, sedate the patient because again that will decrease the catecholamine surge and sympathetic activity. You will give fluid so that the ventricle is filled. It will improve the free load and improve the blood flow across the right ventricular outflow tract. Knee test position, again it will decrease the venous return as well as it will improve the SVR. Pharmacological agents, for the pharmacological agents which are told, they are phenylephrine, which is again for a systemic vasoconstrictor. It increases the systemic vascular resistance directly. And the beta blocker again to decrease the sympathetic activity and reduce the intraventricular spasm. And if the patient's saturation is not improving, you can mechanically ventilate the patient to improve the hemodynamic status. Again, as your participants have mentioned, the ketamine, morphine, or agents which can increase the SPR. Again, ketamine will increase the SPR and no ketamine. You can give ketamine in this patient if the patient is sufficient mechanical ventilation is maintained. There is no contraindication to ketamine. Morphine again will decrease the sympathetic overactivity. But you should not tell ketamine for the primary management. As an anesthetic agent, you can choose ketamine, but for primary management of the chest cell, ketamine should not be mentioned. Morphine definitely yes for sedation to decrease the sympathetic activity and the catecholamine surge. And if saturations are not improving, you can ventilate the patient. What are the surgical options? Again, the surgical techniques include the closure of the VSD, relief of intraventricular obstruction, widening the pulmonary valve and the outflow tract. Here it's a good sized pulmonary annulus, so probably transcatheter patch can be avoided. And it is usually determined by the surgeon operatively by noticing the dilatation with the HEGA. This particular patient did require a transcatheter patch operatively, was performed under cardiopulmonary bypass. Now, when you separate this patient from cardiopulmonary bypass, what are the hemodynamic monitors that you would prefer, and how will you assess the adequacy of repair after the surgery? RV and PA pressures. Suppose you have improved saturation, yes. So there are various methods to know the adequacy of repair. Suppose you have you don't have a transesophageal echocardiography probe in the theatre, you can go by the clinical means. You look at the hemodynamic parameters, you look at the aortic pressures, you actually look at the RV pressures and the PA pressures. Now the RV pressures and the LV pressures are usually taken in sequence, and the ratio of the RV to LV pressures is a very important parameter to assess the adequacy of repair. The PRV-LV ratio of more than 0.8 is considered to have some residual obstruction of the RV outflow tract. So usually it should be less than 0.8. So nowadays we are moving more towards valve preserving strategies and decreasing the extent of resection, so you can accept some amount of residual gradient in the postoperative period. Yeah, 70%, up to 70% of RV-LV ratio you can accept. There are also the options of balloon pulmonary valvotomy, which can be performed in the intraoperative period where you can preserve the pulmonary valve. So that technique has also been adopted by some surgeons. So basically you have to look at the ratio of the RV and LV pressures, and also you have to look at the PA pressures to notice any RV outflow tract gradients. If you have a transesophageal echocardiography probe, you can know the RV contractility, the biventricular function. You can directly assess the RV outflow tract gradient by continuous phase Doppler technique, and also for turbulence across the RV outflow tract. So these are the measures by which you can look at the adequacy of repair. Again, you have used a Cortex patch for closure of the VSD, so residual VSDs are possible. So the echocardiographic assessment should also cover, should look at the presence of residual VSDs while we are screening at the postoperative phase. So this child underwent a complete repair of tetralogy fallow. He was weaned off cardiopulmonary bypass with stable hemodynamics and with the support of dobutamine 5 mics per kilo per minute and epinephrine of 0.04 mics per kg per minute. This child was shifted to postoperative ICU. However, 8 hours later, he developed decreased urine output. The blood pressure dropped to 49/30. CDP had increased to 13, and he had cool extremities. He also had a temperature of 37.5 with a fairly increased heart rate of 160 per minute. So now what could we this is low cardiac output state. So usually it manifests in around 8 to 10 hours after cardiac surgery. This is when you have been aided of low cardiac output in the postoperative phase. So what are the potential causes for low cardiac output in the postoperative phase after a tetralogy repair? RV dysfunction, arrhythmias, residual VSD. So why is RV dysfunctional? Effect of cardiopulmonary bypass, correct? Due to resection. So there is RV is usually the chamber which is likely to be less protected during the delivery of cardioplegia. Second thing is an anterior chamber, so that again has suboptimal myocardial protection during surgery. RV undergoes the resection during the time of appendectomy and also during muscle resection. And again, the protection of the hypertrophy RV musculature deserves special attention during cardiopulmonary bypass. So the causes of low cardiac output state in this particular case, we should rule out hypovolemia, ventricular dysfunction, presence of residual lesions, rhythm disorders, pericardial and pleural connections, and again CPB and cross clamp repeated injuries, and finally sepsis. So CPB and cross clamp related usually can be equated to the inflammatory response associated with CPB, effects of myocardial ischemia from aortic cross clamping, effects of hypothermia on the myocardium, reperfusion injuries which occur at the time of release of cross clamp, inadequate myocardial protection during cardiopulmonary bypass, and ventriculotomy whenever it is performed. So these are the basic causes of a cross clamp or CPB related low cardiac output state. So this particular patient, we had initially optimized the preload with fluids. We hyped up the electrodes. Adrenaline was hyped up to 0.08 micrograms per kilo per minute. CVP had gone up to 17 millimeters of mercury. However, the blood pressure dropped further to 55/32 and the heart rate had climbed to 190 per minute. So what would be your next strategy? Melatonin. But the blood pressure is significantly remaining low, so we were little cautious to start melatonin at this stage, and again heart rate is remaining at 190 per minute. So for a particular patient, we had to move on selection because it's the immediate postoperative patient. Then you should look at the systolic function of the ventricle. So we got a postoperative screening echo. We looked at the VSD patch. Look for the presence of tricuspid revegetation, look for the presence of residual RV outflow tract obstruction, look at branched pulmonary artery flows, look for the presence of the patent foramen ovale. Why is the patent foramen ovale left open in these particular patients? Is there any hemodynamic benefit of patent foramen ovale? So it can be patent foramen ovale can, in the settings of RV dysfunction, can shunt from right to left and maintaining the left ventricular cardiac output. So it is definitely a relief of RV pressure. More than that, it can maintain the left ventricular cardiac output by allowing mixing at the atrial level. So that is the main function of a PFO. So some surgeons do leave behind the PFO to allow to maintain the cardiac output, but at the expense of desaturation. So in our particular patient, there was no collection. Systolic function was actually rigorous, and the VSD patch was intact with no residual VSD. There was no tricuspid regurgitation. The RV outflow tract was wide open. There was free PR. The branch PAs were symmetric and okay. The PFO was small. It was shunting right to left. Then we wanted, since the patient had persistent tachycardia, we wanted to look at the ECG. So we obtained ECG. Since the patient was postoperative phase, we could obtain a limb lead. So this shows the ECG. So in this particular case, when there is tachycardia, we cannot actually make out the P waves. So to enhance the P waves, we usually go for an atrial via ECG. So you can see that the atrial spikes are depicted in the figure. So A wire and the surface lead is in the picture. So you can identify the QRS complex from the surface leads. So in this particular case, you can see that the P waves are preceding the QRS complex. So basically it was a sinus tachycardia initially, but however, we obtained a subsequent ECG later which shows the P waves were absent. P waves could not be carefully delineated. So again, this is another ECG. I'm sorry that I didn't have the A wire of this particular patient. So in this particular picture, you can see that there is a narrow complex tachycardia, and the P waves are irregular. It is not coinciding with the QRS complex, not maintaining a one-to-one relationship. It is coming before and after the QRS complex. So what could be this rhythm? So this, as the participants have mentioned, this is a junction electropic tachycardia. So how do we manage this in the postoperative period? So what are the modalities of treatment? So you can, you have to cool the patient. Here the particular patient's temperature was high, we have to cool the patient, obtain temperature control. So most of one of the important causes is the presence of excessive catecholamines. So you have to give the tachycardia, other modality which are causes for tachycardia in the postoperative period has to be controlled. One is to control the temperature, give adequate pain relief, decrease the exogenous sinuses when feasible. Electrolyte imbalances again can cause tachycardia, so optimize magnesium and calcium, maintain normokalemia. Specific management will be the early institution of the pharmacological agent amiodarone. Sometimes get may be amenable to overdrive pacing when the heart rate permits. Cardioversion is not useful usually in postoperative junctional tachycardia settings. So this is an algorithm which is used to treat the postoperative gait. It's a Brisbane protocol. So confirm the first step is to confirm the diagnosis by obtaining a early ECG and by obtaining an atrial echocardiogram. And you have to give adenosine again to unmask VA dissociation. And once the diagnosis of GET is confirmed, the amiodarone can be given as a bolus infusion. It is usually given as a bolus infusion for the immediate effect. However, the complications of the bolus infusion can be hypotension. We have to give this bolus very carefully over 60 minutes. Meanwhile, you have to stabilize other parameters like normalize the temperature, aim for maintaining normokalemia. Calcium should be maintained. Magnesium should be maintained around 1.5 to 2 millimoles per liter. The case where there's sudden institution of amiodarone can sometimes precipitate bradycardia, so we have to have the pacemaker backup. And catecholamines should be brought down as the blood pressure permits early as possible. And again, reassess and diagnose, reassess every 2 hours. If the rhythm has not reverted or rate control is not achieved to below 140, you can give a second amiodarone bolus at 5 milligrams per kilo over 60 minutes. So likewise, up to 3 boluses of amiodarone can be given to achieve the rate and rhythm control. So once the rate or rhythm control is achieved, you can start a maintenance amiodarone infusion at 10 milligrams per kilo per day. If the patient is hemodynamically unstable and you are not able to give an amiodarone bolus, you can start an infusion at a slightly higher dose of 20 milligrams per kilo per day. So this patient responded to amiodarone, rhythm came down, rhythm was converted to sinus rhythm, rate control was achieved. Patient was then supported with mechanical ventilation. Once the blood pressure is improved, inotropes were tapered. Patient was sedated and paralyzed initially for the maintaining the hemodynamic stability. He gradually improved over 24 hours, peripheries became warm, pulses became well felt, and the blood pressure improved. The inotropes could be weaned down to minimum inotropes of dobutamine at 5 miles per kg per minute. Patient was subsequently weaned and extubated on postoperative day 4. So basically the take-home message is that patients with in the postoperative period can present a low cardiac output state. You have to go in a systematic fashion to identify the causes of low cardiac output state so that you do not miss any particular cause. So serial examinations of serial clinical examinations as well as echocardiographic evaluation has to be done at the bedside to rule out the causes of low cardiac output and to treat the appropriate cause. And always it is important to obtain a baseline ECG to rule out the basal rhythm, and also rare ECG to rule out arrhythmias in the post-operative period, so that appropriate management can be instituted. So I hope both the case scenarios are clear to you. If you have any doubts regarding both the case scenarios, you can ask. Usually the physiological peak which we mentioned is around 3 to 5 centimeters of water. Usually you can keep up to 3 to 5 centimeters of water in the post-operative period. But you should be cautious when you are using a higher peak beyond 5 centimeters of water. And without strategy, the most important thing is you have to choose a strategy which uses the lowest mean airway pressure. So adjust your ventilation setting so that the mean airway pressure doesn't increase to very high levels. So this is basically achieved in pressure regulated modes, whereas the volume control modes usually have a higher mean airway pressure. And always go for early extubation because spontaneous ventilation will promote low airway pressures and improve the pulmonary blood flow. Any more questions? So usually millinol is a very controversial isotope in the post-operative period. There has been a lot of literature coming up about millinol facilitating catheterisation arrhythmias in the post-operative period. Several recent meta-analyses has come up which shows that millinol is associated with atrial fibrillation. So the use of millinol is indicated only in specific situations like a transposition with an intact ventricular septum where you need a significant absolute reduction, or in a AV canal patient with severe AV regurgitation, or an anomalous left coronary artery compounded artery with AV regurgitation. So there are some specific indications in the congenital heart disease settings where millinol is indicated. There is actually no role for the use of millinol in the patient with deteriorative palate. And in low cardiac output state, the choice of millinol will actually depend upon the cause of the low cardiac output. If you see that systemic afterload, increase in systemic afterload is a cause for low cardiac output state when it is justified in starting. And also an additional setting where millinol is justified is in a case where you have a significant residual ventricular septal defect where you need to decrease the afterload and decrease the shunt across the venous where you opt for millinol. So other than these specific indications, millinol should not be irrationally used in congenital heart surgery settings. Levosimendan has been increasingly used in pediatric cardiac settings. Levosimendan is actually a calcium sensitizer. It is actually devoid of complications related to tachyarrhythmias in the post-operative period. So we have been using levosimendan in quite a few settings. Levosimendan actually decreases the afterload. It can decrease the appendicular and diastolic pressure. So it can achieve almost all the actions of millinol without producing the tachycardic effect. However, major randomized controlled trials in levosimendan in pediatric settings is yet to come up. Again, an single dose and effect will be effect can last up to 24 hours, and the effect of a continuous infusion can be given up to 1 week. The loading dose has to be given over 10 minutes. You have to watch for hypotension during this period, and beyond that, an infusion for 24 to 48 hours. So the effect of levosimendan will be persisting in the circulation for over 7 days.